All right, welcome back to the Black Brain Trust. This is episode 882. I'm here with my colleague, Dr. Phoenix.
Good evening, everyone.
All right, please hit the like button as you come in, share the video if possible, and hit that notification bell so you get all the updates from the Black Brain Trust. What we want to discuss today is whether or not the U.S. healthcare system is broken. Let's start off with this article that is on screen. This is from Business Insider. A former U.S. Surgeon General says he went to the ER for dehydration and ended up with a $5,000 bill. He called the healthcare system broken. Zoom in. A former U.S. Surgeon General just got a taste of what frustrates countless Americans, a massive medical bill. Dr. Jerome Adams, who was the nation's top doctor from 2017 to 2021, said he was slammed with an almost $5,000 bill after being treated for dehydration at a Mayo Clinic emergency department where he got labs and a few IV bags. He first shared his experience on X, formerly Twitter, and a post that went viral. In an interview Monday with Business Insider, Adams said he went to the ER in Scottsdale, Arizona in January after he became lightheaded while hiking on a work trip. He said getting the big bill was shocking, even for a doctor well acquainted with the pitfalls of the U.S. healthcare system. Spending hours on the phone with hospital billing reps to get a clearer picture on why he was charged so much had been mentally taxing, he said. The Mayo Clinic didn't immediately return the request for a comment. Adams said his experience highlighted the exorbitant cost of medical care in the U.S. and the lack of price transparency. Patients usually have no idea what a medical visit will cost ahead of time. And even if they do, it's impossible to shop around in an emergency. At the same time, patients increasingly shoulder a larger portion of healthcare costs as insurance deductibles have crept higher. Adams said that with all these obstacles, it was no wonder many Americans ended up with medical debt. Quote, if I'm in this situation with my knowledge and with my financial resources and with my bully pulpit, then the average Joe doesn't stand a chance. The system is just broken, Adams said. Medical debt is a widespread problem. An analysis by the KFF and the Peterson Center on Healthcare suggests that 20 million people in the U.S. owe medical debt and 14 million people owe $1,000 or more. Research has shown that medical debt is a leading cause of personal bankruptcy. It's unclear why Adams' bill was so high since he said he hadn't received a breakdown of the charges. ER bills are notoriously expensive and can vary drastically from hospital to hospital. Adams said he was billed for a level 5 visit, which is a code used for patients with the highest level of severity, such as chest pain or stroke symptoms. The most complex cases fetch higher payments because they require more resources and time. But Adams said he was fighting the bill because he believed his visit should have been coded at a lower level. Now, Dr. Phoenix, what's your take on the coding of these ER visits?
So typically, when you come in for an ER visit, for something like what Jerome Adams came in for, or I can give you an even personal example of me. Years ago, I had to get a few sutures and I ended up with I think it was like a $1,700 bill for like maybe 4 or 5 sutures. And so typically how, I guess the easiest way to put it is that when you bill for the highest incident level, so level 5, when you bill for the highest level, again, this is the way hospitals make money, but also to understand that you have procedural. This is the way the healthcare system works is really fee for service, and in particular, procedures such as, let's say, doing sutures, or more importantly, when you start to, for someone like him, he might have had some diagnostic work done, perhaps. I'm not sure. But again, laboratories, diagnostic work, and anything that's procedural based run high incidence levels. We're talking usually level four to five, and these are where hospitals can make big bucks. And one of the things I did, there was something in the article mentioned about deductibles, health insurance deductibles.
Let me read that as well.
Yeah.
Another issue is that Adams is enrolled in a high deductible health plan, requiring him to pay thousands of dollars out of pocket before he reaches the deductible and insurance starts picking up part of the tab. High deductible plans have become more common as employers have shifted the cost of medical care to their workers. A survey by KFF found the average annual deductible for individuals in one of these plans attached to a health savings account was $2,518 in 2023. Adams said his deductible was a whopping $7,500.
Ooh, wow.
The health plans allow patients to put pre-tax money in a savings account each month to help them afford their medical bills. But Adams said that since his ER visit occurred in January, he hadn't built up any savings. Congress has provided some relief from unexpected medical bills. The No Surprises Act, which went into effect in 2022, is supposed to keep patients from getting stuck with a surprise bill if they inadvertently receive care from an out-of-network doctor. But Adams said patients should have a better sense of what they'd be required to pay ahead of getting care and more clarity about their options when they get a big bill. He also said patients shouldn't face drastically different costs for the same care at different facilities. Quote, people are so scared of these bills due to a lack of transparency. They actually just don't go in at all until it truly becomes an emergency, he said. So Dr. Phoenix, healthcare savings plans, what's your take on the system as it stands based on the Jerome Adams situation?
I think this has been a trend that's been going on for the better half of the last 2 decades, where more and more of the responsibility, the financial responsibility of healthcare and healthcare insurance in particular, has been shifted onto workers. And so I would say, from my personal opinion, because I am a veteran, I'll be really frank about that. So I don't have high health deductibles in particular, but I know many people who do. And in general, the way these high deductible health plans, they claim that they're supposed to help lower premiums, but they really don't, because more likely than not, people are paying minimum $2,000 plus before the plan even kicks in, and the costs are even covered. And so, and if you look at it on average compared to, let's say, an HMO or even like a PPO type plans,
please explain to people what an HMO is and a PPO is.
So we're talking like health maintenance organizations or preferred provider organizations. And so essentially, they operate essentially the same. And basically, as the name sounds, preferred provider organizations, that's basically based on what customers like. If they have someone that they have a provider that they like, that they prefer, that's generally, those are what those plans cater to. But in general, PPOs and HMOs typically have lower deductibles. So maybe like $1,000. HMOs, I still say HMOs and PPOs are still offered by many employers, but I can tell you from my own personal experience that I've seen more and more people who have high deductible health plans. And so again, that's that's like when people come through the door with that, I mean, they're eating all of that up front, to be frank. So if you think of the typical ER visit costing, let's say $1,500 to $2,000, what's really the need to have health insurance? Again, if you're coming into an ER, and let's just say, for something like dehydration, that's pretty standard fare. There's nothing involved or routine or anything like that. I mean, just pretty routine type of stuff, scenario per se. But however, if you have one of these high deductible plans, that in of itself is kind of counterintuitive. So why even have it when you're gonna eat the cost anyway? Do you understand what I'm saying? It's really a catch-22. It may be beneficial if you actually have a serious health emergency that requires you being hospitalized or require more intensive treatment and services and such. But for those who don't, but just coming in for something routine, an urgent care visit, truth be told, I'm not sure why he went to an ER. He's in Arizona. Their urgent care is all over the place in Arizona. He was probably better off going to urgent care and probably would have paid a few $100s, if even that. Probably would pay, maybe $1,000, but wouldn't even pay nowhere near as much. And again, I'm not sure what he does now, since he's no longer the Surgeon General, where he will have a high deductible health plan. But I will say that, yeah, for the most part, folks who have high deductible health plans, it's not even worthwhile to even truly. You're better off not having insurance, to be honest with you, because more likely than not, if you carrying, like, I think the article said that he paid $7,000 out of pocket.
You have to pay up to $7,500 out of pocket for a
no,
high.
I thought the article stated that he paid $7,000 out of pocket.
No.
Okay.
That's what the plan is. That's what the plan is. And the reason why he had to go to that facility was because he had dehydration on the hiking trail. So I think that was the closest facility he can get to.
Okay. So in general, my general response to that would just be that in his case, I wouldn't even see, he wouldn't qualify for, like, and I think the article you was reading, the article where they were talking about, hospitals having various various plans or programs to try to help out clients who might not be able to afford it. But again, you're sitting on the phone with these folks, administration and folks from a lot of nonprofits get involved at this point. You sit on the phone with folks for hours on end, and that in of itself becomes really frustrating and time consuming. I mean, you people. I've seen it in several clients where they, they get suggested, they're suggested that they apply for this program that will help offset some of their medical costs. But then, they're telling me, oh, well, I'm sitting on the phone for 3-4 hours and then I still don't get no answer. And then I'm just told, well, you got to go complete this form and then mail it in or call us back here. And so basically these folks ultimately end up just kind of going in circles in many respects.
I mean, he's, middle class, pretty well off, but if you're a person who is low income, you can get torn out the frame by just one medical visit. They want to charge him for the ambulance ride as well. It could be anywhere between $1,000 to $1,800.
Yeah, I mean, again, we're living in a society now where, how can I put this? It's essentially one of these deals now where so much of what happens, so much of the cost of just things that normally just, 20 or 30 years ago would be shared costs, much of that's getting shifted towards consumers and workers. And this is one way companies, organizations, they can boost their profits, is by shifting a lot of that health insurance, the health insurance cost of premiums over onto the worker themselves with high deductible premiums. And again, this is something that is going to be just necessarily solved through legislation per se. There has to truly, in my honest opinion, there truly has to be a movement to truly address why is this happening?
Right.
Again, everyone can, all these companies, it doesn't matter whether it's the automotive, whether it's the automotive industry, the aviation industry, whatever industry you can think of, this is what they all do. I mean, I can't name the number of times as a nurse that I've sat on the phone with folks, sat on the phone with insurance companies, done, trying to help get patients into certain programs to help get them qualify for certain programs. And again, it's frustrating. And I think a lot of times people, when you're on the outside looking in, people look and say, oh, well, it's the physician's fault, it's all these healthcare professionals' fault. They're not, no, they're just, I guess you consider them a cog in a machine, if you will, but not even really necessarily a cog. They are a necessary product of the industry, but more or less, they represent sort of that they represent that point of interaction with the industry. Much of what happens to patients doesn't happen, believe it or not, with you and the healthcare provider. It happens between you and that whoever's your health insurance provider. That's what ultimately happens, and that's who have the ultimate say so. Everything that healthcare providers do is all within the parameters of whatever insurance dictates or says they can or can't do, or what they will or will not pay for.
Yeah, I mean, I agree with Dr. Jerome Adams that it should just be one flat rate across the board. I don't understand why different, you go to one ER, it's a different price. I thought ERs were ERs, why? I mean, what? It's supposed to be a standard level of care. Why is it such
because
varying?
Because they're not all the same. If you go to let's look at Atlanta, for example. You think of some of the major hospitals in Atlanta: Piedmont Health, you have Emory Health, you have Grady. Now think about what these three organizations, these three entities I just named, think about where they're located. Emory is over there in that Decatur, that border between Decatur, Midtown, Buckhead area. And then you have Piedmont, they're kind of over in that Buckhead area as well, that Decatur area also. And then you have Grady, that typically services more or less a Black population. So typically that downtown Morehouse, Spelman area, that downtown South Atlanta or South Fulton County area, if you will. You think about who the populations that they service, and so the ER, for example, at Grady is not the same as the ER at Emory, if you take it. And here's part of the reason for that, which is that if you think of where's the need the greatest at. So if you think of it sort of like areas of economic deprivation, if you will. You think about where people have the most financial distress at, what parts of the city, what parts of a society where you see the most economic distress. Those tend to be places where hospital systems and ERs in particular are overwhelmed, because you have people who don't have basic access to providers. And so because they don't have basic access to providers, we've talked about this in the past, ERs again become these staging grounds for what should be for what is primary care, or really should be for more acute emergent situations, but really they become staging grounds for preventative and primary care based services. And so then you look at it, then you go to a place like, let's say, Piedmont or Emory, which tends to service clients that have higher incomes, that are more affluent, live in more affluent areas. And so you don't see that, because the general population that system services is generally healthier, if you will, but not just healthier, but even if they had to pay something out of pocket, they could afford it.
What role does the Affordable Care Act play in this?
Well, the Affordable Care Act was designed to make insurance um, uh, cheaper, more accessible for everyone. Again, I mean, you do have that you do have the mandate and stuff like that. And I think, there are exceptions to that, like the veterans, for example. Um, it was designed to make it more affordable, but in many respects, you still have private insurance companies still have a lot of control over that. It just makes this big, it's kind of like walking into your favorite, auto dealership and looking at several cars you like and trying to pick out which one you want.
Mm-hmm.
It's a similar type of process in that respect. And so it becomes one of these deals where it's not just about the Affordable Care Act, it's really about the society as a whole. This is a societal issue. And more importantly, this becomes a issue of whether or not people believe that there should be a shared responsibility between employer and employee on providing insurance. If you're working for a company, especially for folks who work in more high risk types of occupations, a lot of folks who work in blue collar jobs, those tend to be high risk occupations where you're more likely to incur physical injuries. And so it might, for some people, it can lead to early retirement, or it can lead to sometimes life-changing disabilities. But what's more prevalent is the fact that as a society, much of what happens and when it comes to health insurance is that at least what's been going on for the last 20 or so years is that these costs have been consistently shifted onto consumers and onto workers. And so there's no counterbalance because companies can free up, they can make more profit, they can make more money by shifting these costs to you. And again, for folks who, for example, who have high deductible insurance premiums, I mean, in my honest opinion, I don't even think they're worth it. I really don't, because I've known several people who have them, and they even if they just go, I know several women who have them, and the deductible is so high. If they want to do something, let's say like typical stuff that women deal with, if they have to do any diagnostic testing, laboratory testing, blood draws, X-rays, CT scans, MRIs, stuff like that stuff costs thousands of dollars.
But what are they doing that makes it cost thousands of dollars, though? Most of the stuff is automated.
Well, because it's not automated. That's the thing. I think automation becomes this nice little catch-all phrase, but in healthcare, things are not automated like that. Healthcare and the practice of healthcare and of healthcare delivery of medicine, of the delivery of medicine, of medical services, that is still very much a hands-on process. People are never going to, in my opinion, I don't think people will ever be comfortable talking to some prompt or talking to some digital assistant or whatever, telling them what's going on. Especially, I can imagine a woman coming in and having to talk about some things. No, I don't think people, and men too, I don't think people will ever truly be comfortable with the idea of talking to some AI assistant or some digital assistant and then having them do a workup and order tests. No, you want to be able to talk to somebody because there's so much of what happens in healthcare, yes, as I said earlier, is determined by health insurance, but your interaction, your point of care, your point of contact within that healthcare system is going to be generally that nurse or that physician.
One of the things,
be your point of contact.
I was just going to say, one of the things that that we've talked about this before is that Black men are one of the most impacted demographics of people in the country who don't have access to quality care. We saw that during the pandemic. And so when you see somebody like Dr. Jerome Adams with a $5,000 bill, that might be okay for him to pay. But if you're a Black man who's either low income or doesn't have any income at all, you can get torn out the frame pretty quickly. And it could be bad. It could be worse.
Yeah, no. So on the whole, let's just be frank here. Most black men tend to work in occupations that are high risk, i.e., they work in occupations that are prone to injuries, physical debilitations, generally occupations that require some form of physicality, some physical manual labor performed, and and that in of itself creates a lot of wear and tear on the body. So for a lot of these men, for most of these men, by the time they're in their, if they, let's just say they started when they're in their late teens, maybe early 20s, by the time they're in their 30s or even approaching their 40s, many of these men have bodies that are, that are worn, for lack of a better term here, but they they have mileage, if you will. These bodies have gone through considerable stresses, and so stressors, excuse me, and so they present with a lot of issues, back issues, spinal issues, issues with walking, gait. Some men have nerve damage, all kinds of issues. And again, too, that's I'm talking about. A lot of what I'm mentioning now is more neurological. But once you start to think about some of the musculoskeletal issues that that men have working in these professions, on top of just in general, men who work these types of professions tend to have unhealthy lifestyles to begin with. So they're already they're most likely going to present with other chronic health issues, diabetes, pre-diabetes, obesity. And so these heart, cardiovascular issues. These are all things that come about. And for black men in particular, black men are overrepresented in these types of occupations and professions. And by definition, a lot of these professions don't typically offer good health insurance to begin with, if any at all.
A lot of them are pay under the table because of other, sort of, ways of having to get around, the typical minimum wage that might be established in some areas. Maybe this might happen more in the South than it does in the North, but I have seen a lot of black men, have to get paid under the table because they have other sort of pressing issues, such as child support or other sort of prevailing issues. And so, you compound that with somebody who just does not have any insurance at all. He might try to walk it off until it gets to the point where he can no longer walk it off. Just talking to a colleague in the barbershop, and he was telling, we were talking about a childhood friend whose stomach kept hurting. His stomach was hurting so much, by the time he got to the hospital, it was too late. He had internal bleeding on the inside. He just ignored it. He was just thought he can just kind of alpha his way through it. And he found out the hard way. He died. He wasn't even 40 years old yet. And so this is the sort of things that I think that black men are running into. Even in regards to this article, you have a pretty middle-class black man who's running into this issue. And then you take into consideration a lot of black men who are not even having any income. You have a recipe for disaster, because I think that black men become the canary in the coal mine for how the system works and where it breaks down and where it needs to be remediated.
No, I would agree. Black people, but black men in particular, are the canaries in the coal mine, have always been. I to go back to something you mentioned earlier, a question you asked earlier about why are some of these, why are the various services are so high? You have to understand that when people think of the healthcare system, people just think, oh, I go to the hospital, I'm a part of this HMO, or I'm part of this PPO, I'm part of this, I'm in this network or this particular healthcare organization, Ascension, Kaiser Permanente, some of the other big ones out here. You think of some of these major healthcare organizations, and people don't really consider that a lot of these services, laboratories, stuff like that, a lot of it is in-house, but a lot of it, especially if you go to some of these standalone clinics or even standalone ERs, there's a such thing as standalone ERs. urgent care clinics, for example, a lot of this stuff gets outsourced. So you have players at every level who they all provide a service, they all provide whatever, and they charge whatever it is that they feel that they want to charge, or what is considered quote market rate. And so one of the things that I would like people to take away from this is to understand that the healthcare the sum of the healthcare system isn't just quote the physician and the health insurer, no, or the provider and the health insurer, whatever. It's all of these other players, the folks who create the EMR systems, the Epic and Allscripts and some of the other big ones out here. Epic is the gold standard, but there are many other EMR systems out here, and these systems cost massive amounts of money. You think of a major healthcare system, let's say like something like Kaiser Permanente. These are healthcare conglomerates that are not just in one singular state; they are spread across multiple states. And so imagine having to implement something, let's say like Epic, into this entire healthcare conglomerate. We're talking just doing this alone will cost these systems hundreds of millions, if not billions of dollars. And that will get passed on in the cost of services and everything else. The hospital stays and the cost, the various costs for laboratory and other diagnostic work. So again, I want people to understand that the sum of the healthcare system isn't just the provider and the insurer and you. No, it is the provider, the insurer, you, and all these other folks. If you have there are certain things that are there's if you think about some of these medium-sized or smaller health systems or community-based hospitals, if you will, a lot of times these folks have to outsource. They don't have specialists on hand. They don't have a cardiologist. They might not have a cardiologist on hand. You go to a mid-sized city, and you go to a hospital there, they might not have a cardiologist on hand. They have to outsource. They have to contract out for stuff like that. That stuff can run. It can get insanely expensive. But go ahead.
I mean, I was just gonna ask. One of the final questions is like, from someone who works on the inside, how would you, what are one of the areas that you would actually, come up with a innovative solution to solving this sort of issue, or is it too big to solve?
I do think there are a lot of things you do in healthcare are routine. So I think I think something you said earlier is actually a pretty reasonable, a part of a reasonable solution to that, which is that there should be a set rates for certain services. Again, I've seen thousands, if not tens of thousands of blood workups and laboratories for blood and all that stuff, and most of that is routine. Okay, a lot of stuff that gets ordered is routine stuff. These folks do this stuff thousands of times a day. It's the same thing. It's the same process in and out. X-rays, routine. And so I think that there should just be a basic set rate for these services. So if you need an X-ray, this X-ray costs, and there are some places that do that, but this again, we're talking about an issue that is systemic. Just because you have one particular organization that does it is not ubiquitous across the entire industry. And so as a whole, you can have a few organizations that might do this, but many organizations don't. And in particular, I would tell you now, rural care, if for folks who live in rural or areas who don't have healthcare access, don't have adequate healthcare access, those are where you see some of the highest costs.
Is there a difference between the VA and non-VA sort of
Well,
care?
the VA, keep in mind, I mean, VA is about as close as you're going to get to socialized medicine. I mean, and to your question earlier about the Affordable Care Act, that's what the Affordable Care Act should be. It should mimic something like the VA health system. Now, I will be the first one to tell you that the VA healthcare system sometimes is not the greatest, but a lot of it very much depends on where you go and where you're located. You know, VAs in certain states and certain cities are just not good, and VAs in others are quite good. And so, I will say that, in my opinion, that the Affordable Care Act didn't go far enough. And more importantly, what the healthcare system should look like in this country should look something similar to what you see with the VA. I mean, that's about as close as you go get, but I don't think there's the courage nor the will in this country to do anything like that, to implement a healthcare system on that scale, some that would be similar to the VA.
My final, yeah, go ahead.
No, I was just gonna say, when you think about something like the VA, I'm no stranger to some of the issues at the VA, but I will also say too that, for a lot, you don't hear stories about veterans paying insane premiums. They're at best, they're paying maybe $100 or a couple $100 for some medications, most likely less than that, usually like $35-$40 if they have to pay something. So, you don't really hear or see stories like that when you're talking about veterans and the Veterans Health Administration system. What you're seeing are folks who are obviously, they're not veterans, but they're just, regular rank and file citizens. And these are everyday lived experiences that they're having. You walk into an ER for something mundane, something very routine, but you walking out with a $2,000, $3,000 bill. Like I said before, the example I gave years ago, I had to get I think it was about 4, maybe 5 sutures, and had like a $1,600 bill for I think they had me sitting around there for like 2 hours.
So you paid about $450 a suture.
Yeah. And this is in Chicago. And again, this is this is a city, high cost of living, city with a very high general income among people. But I think in many ways the healthcare system is broken. To just really sum it up, it is broken. Because the fee-for-service model, every provider knows the fee-for-service model isn't sustainable. It doesn't really work. But again, fee-for-service model isn't dictated necessarily by providers per se. It's really more or less dictated by the health system and by the healthcare organizations themselves. Because if you had a flat rate for everything, people wouldn't make no money.
Right.
There'd be a lot of folks get put out of business. But right. you have a system where you have all these players and all of these folks kind of cannibalize each other in many respects. There's a lot of overlap of services, a lot of overlap of what various things that can get done or can happen or whatever, and there doesn't need to be, which also contributes to a lot of the cost. But more or less, what you're seeing here, this story in particular, a lot of this is not just per se the employers. It is really, a lot of it falls dead smack onto the health insurance providers themselves. Because just imagine you had, you were in a serious car accident, and you had to be hospitalized for, let's just say a week. you're already looking at a hospital bill somewhere around the neighborhood of probably 50, 60 grand, depending on where you go. It's probably higher depending on where you go. They send you to one of these really top tier hospitals, one of these major academic research centers. Yeah, you're probably looking at $100,000.
Yeah.
But
And
before they will even begin to touch that bill for you got to go drop down. Let's just say you got to go drop down 10% of that, $10,000 straight out your pocket. And how many people realistically have $10,000 just sitting around that they can devote to an emergency medical bill?
most Americans don't even have $400 in their savings.
Yeah.
I think one of the takeaways for me is that instead of these big shockers of a healthcare bill, medical bill, I think they need to offer a way to pay it over 12 or 24 months. $2,000, sounds like a lot to someone who's poor, but if you break it over 24 months, that's something that can be negotiated at the end of the day. Telling them that pay up $2,000 up front when they don't have it doesn't make a whole lot of sense, especially based on their income. And so I think that's one of the ways that can actually solve that.
I will say a lot of hospitals, I have not seen a hospital or a healthcare organization that doesn't offer, monthly payment plans where they spread it out over the course of 2 or 3 years or something like that. Pretty much every place I've seen work that, they offer something very similar. However, one of the other fundamental issues here is that, and I think the story of Jerome Adams is kind of a testament to that, which is that he's a physician. He has the income that he can afford to pay that. But most people in America don't. And I think I think part of what gets caught up is that people look at major cities, they look at, New York or Boston, Chicago, LA, DC, Atlanta. They look at some of these places, and I can tell you from personal experience in Chicago, Milwaukee, Atlanta, I can tell you right now, these places, especially Atlanta, I can tell you from personal experience, these places, Black folks can't afford your rank and file Black person, Black patient cannot afford a medical bill in Atlanta. I can tell you that. The same was true when I was in Milwaukee, and the same was true in Chicago and some of the other places I've been over the years. And I can tell you, the rank and file Black person can't afford a $500 bill, let alone a bill that costs a few $1,000s. And more importantly, when you break it down along gender lines, and you start to include children into the mix, you will find most Black children are on Medicaid, or Medicaid recipients. So they're either on state, they're either recipients of state HMOs, like in Georgia they had Peachtree. I forgot what it was called in Wisconsin. I can't remember the name. But pretty much all states all have their own managed health plans that fall under that purview of Medicare, that gets funded through Medicaid, through CMS. And so they, I can tell you now, when you start to include children and women into the mix in particular, then the disparity just goes through the roof. You're seeing even a bigger chasm between folks who can pay and folks who can't.
And those are the folks who avoid going to see the doctor for any reason.
Yeah, ultimately that's what it comes down to. People put off those health issues until they can no longer put them off, and then what might have been a relatively simple issue to deal with, it becomes this big cascading issue. Now you might require surgery. That's gonna run up the tab some more. You might require some other supplemental services. That's gonna run up the tab. I mean, once you start to have these cascading health issues, for example, you think of somebody who, let's just say people who have cardiovascular issues. Let's just say it led to a stroke. Now you have to be in a neuro ICU. Now you have this internist or this neurologist seeing you. So now you have at least two different specialists of physicians looking at you. Then now we got to bring in some occupational therapy. We have to bring in some speech therapy to help you learn how to talk again. If you even, or at least get you to a point where you're understandable. Then you started bringing some of these other rehabilitative services, and that tab easily balloons from, maybe 10,000 to 20 to 30 to 40 to 50,000, very easy. And then you start to tack on labs and other diagnostic work, CT scans, and then you start to throw the medications into the mix. You're easily looking at medical bills cascading, ballooning into the tens of thousands, even hundreds of thousands of dollars for an issue that probably could have been dealt with by your rank and file primary care provider before it even got to the point where it became so serious. Now it's this. Now you might be looking. You done had a stroke. You might, maybe you might have had a heart attack. Maybe you might be looking at heart failure. So again, these are all things that, preventative issues, when they're not dealt with, become big cascading health issues. So,
Dr. Phoenix, thank you for joining us. Really appreciate it.
No, I appreciate it, brother. Thank you for having this conversation.
Absolutely. Thank you all for joining us. Please hit the like button on the way out, share the video if possible, and hit that notification bell so you get all the updates from the Black Brain Trust.